Non-Standard Advanced Directive Ethical Dilemmas by Colleen Aaron and D.J. Lay. Our objectives: to define advanced directives and DNR orders, show examples of different advanced directive forms, provide scenarios that include ethical dilemmas and decision making, case study of ethical scenarios, and recommendations. What are advanced directives and DNR orders? The definition of an advance directive is a legal document that allows you to spell out your decisions about end of life care ahead of time. They give you a way to tell your wishes to family, friends, and healthcare professionals and to avoid confusion later on. A do not resuscitate order, or DNR order, is a medical order written by a doctor. It instructs healthcare providers not to do cardiopulmonary resuscitation if a patient's breathing stops or if the patient's heart stops beating. Non-standard DNR directives include things such as DNR tattoos and DNR medallions. This is an example of an advance directive or a living will. It allows the patient to state how aggressively they would like to be treated in the case that they are dependent on life support. This is an example that shows that they have different options. That if their death is imminent and they are permanently unconscious, that they would like cares to be withdrawn and just to be kept comfortable in controlled pain. The second is, even if my death is imminent or I'm permanently unconscious, I choose to prolong my life. The third option gives a little bit more leeway, as it says I choose neither of the above options, and it allows them to spell out exactly what they want on the form. It does require either notarization by a notary public or two witness signatures to be considered legal. This is an example of a Comfort One form. This is actually a form that has gone statewide sometime in the past year, and it is specifically for emergency medical services, responding to patients that have coded in their homes. It, in effect, is a DNR order. It does require the patient's signature, and it also requires the signature of either a physician assistant, or a nurse practitioner. On the second page, it does spell out what EMS will do for a patient that is a Comfort One patient and what they will withhold or withdraw from the patient. The third page on here is just information about ordering a Comfort One bracelet. If a patient has a Comfort One form filled out and the order on file, they can wear that bracelet to indicate to EMS that they have one of these filled out. This is a MOST form. It stands for Medical Orders for Scope of Treatment. It is just now, within the last month and going forward, going legal statewide for South Dakota. It's a standardized form instead of each facility having their own forms that spell out different things. Other states have similar forms. They are MOLST or MOLST forms, or POLST, POLST forms. That stands for Medical Orders for Life-Sustaining Treatment, or Physician Orders for Life-Sustaining Treatment. This is, in effect, both a DNR and a living will all balled into one. The first page indicates 5 different topics that are addressed with the patient or the patient's representative, such as power of attorney. The first is CPR, whether or not CPR is wanted or whether or not it is not. The second part is how aggressively they want medical interventions done. The third is the question about whether or not artificial nutrition and hydration should be continued if they are requiring full life support and that's all that's keeping them alive. The fourth is the informed consent discussion. It's just a signature that the physician has gone through this and that the patient or the patient representative understands the full implications of this order. And the fourth is the basis for these orders: the patient's declaration. The second is the patient's authorized representative, the power of attorney, the patient's advance directive, if they have one and it indicates that they do not want aggressive treatment measures, then and they lose their capacity, the physician can fill this out. And the fourth is that resuscitation would be medically non beneficial. It does require the signature from the medical provider. It does require the signature from the patient or the patient's power of attorney. On the second page, it does have a lot of things that are uh, listed. It requires regular review, and it can, in fact, be changed. It can be completely revoked, or different things can happen with this at any time. It just requires review and a new order to be signed. This is an example of a durable power of attorney or medical power of attorney paperwork. It allows the patient to provide up to 3 people that they are comfortable with making decisions for them if they are unable to make decisions. They do go in order. So the first person is the primary power of attorney. If they are unwilling or unable to act, then it kind of rolls downhill to the second and the third. It does say on the form that the patient can authorize their agent to make full decisions. It also gives them the opportunity to say that they only want certain decisions made by their power of attorney. This is just an example of just a really regular, common advanced directive. It kind of allows someone to say in their own specific words what they want. This is mine, as you can see. I filled one out. The 5 wishes are the person I want to make my care decisions for me when I can't, the kind of medical treatment I want or don't want, how comfortable I want to be, how I want people to treat me, and what I want my loved ones to know. We did find an article on CINAHL that addressed some ethical dilemmas that relate to do not resuscitate orders. I placed a quote here. I'm a surgical nurse in a small hospital. 2 of the surgeons on staff have conflicting approaches. One will honor a patient's wish not to be coded during surgery if a patient has a do not resuscitate order in his chart. But the other surgeon insists that all patients be considered full code during surgery, regardless of the DNR status. He's told me he's concerned about his legal liability if he, quote, lets a patient die on the table, unquote. Who is right? Well, the first physician is allowing patient autonomy so that they can make their own decisions, and he's honoring their decision. The second physician is taking a lot of other things into account. Maybe they had a anesthesia related incident that with quick treatment would restore them back to normal, and the anesthesia reaction had 0 to do with their terminal illness. I would say that in my own experience during code situations, that there's always at least one physician, several nurses, respiratory therapy, and several techs that are present. After so much time is spent on a code, most physicians will turn and stop and say, as we continue to resuscitate the patient, this is what we've done. We've exhausted our options. We've been coding the patient for this long. I believe it's time to call it. Does anybody object? And at that time, anybody, regardless of their rank or status, can object, and their opinions are taken into consideration to continue coding the patient. We were able to interview Dr. John Travnicek with Avera Medical Group Emergency Medicine and give him certain scenarios and ask him, in his opinion, how he would respond.
Scenario 1, you are the first responder arriving at a vehicle accident site where a car and a motorcycle has a collision. You notice the motorcyclist laying on the ground and they look to be in serious condition. The motorcyclist is not breathing and he is not responding to simple commands. You notice a DNR tattoo on his right arm. What are you going to do? In this instance, the DNR tattoo would not be honored unless they have uh, a signed DNR form with the physician and his signature on it. Uh, Otherwise, it should not be honored in this situation. So, the second scenario, a family brought an older gentleman into the emergency room. The patient reported having chest pain and breathing problem. After a few minutes, the patient goes into cardiac arrest and was not breathing. You check his file and saw that he has a DNR on file, but the DNR was signed 4 years ago. You report this to the family members, and they said the patient changed his mind about a year ago. The patient wants our medical intervention because he wants to live. What are you going to do? This is a difficult situation for the physician, considering he has a signed DNR file in the patient's profile, and now the words from the family members that the patient changed his mind. Um, so John said that in this situation, other factors would come into play, like if the patient has end-stage cancer or serious diseases, then the DNR will not be honored and let him pass. Or if he's in relatively good health, then he will be resuscitated back to life, so he can make his wish known to the family and to the doctors. So, the third scenario, an adult female patient has been admitted to the ICU for several days. She is in a coma and on a mechanical ventilator. Six of her children has arrived to visit with her. Her chances of recovery are slim. Her file does not show any advance directive or power of attorney. The family members are asked to decide if she should stay on the mechanical ventilator. Half decided she should stay on, and the other half wants her off. What should you do? In this scenario, the correct thing to do is to keep her alive until a general consensus from the family members are made. So in this instance, the physician has the ability to invoke the principle of not choosing an irreversible path when facing with uncertainty. This means that it is um, better to keep the patient alive with treatment, because the treatment can be taken away rather than just let him die and have no other options, because you can't bring the patient back to life. So, so the case study: a 70-year-old male was found intoxicated on the street and was brought to the emergency department by paramedics. The patient had no identification or family present. He had a do not resuscitate tattoo and signature on his chest. Initially, the provider did not honor the DNR tattoo. The patient was treated with antibiotics, IV fluids, vasopressors, and bi-level uh, positive airway pressure. The providers eventually found out his identity. The social work department was contacted to find his next of kin. An ethics consultant reviewed the case and advised the providers to honor the patient's DNR tattoo. The patient died the next day without advanced airway management by the providers. The social work department find, found an out of hospital DNR that matches the patient's tattoo.
In conclusion, based on current literature and professional opinion, non-standard advance directives such as DNR tattoos and medallions should not be honored without a legal form or a family member present. If healthcare providers have access to medical records that indicate secondary disease states, they are allowed to honor the DNR tattoo without the actual form as part of their clinical judgment.
Our recommendations are that education about advance directives and the importance of communicating your wishes to your physician, other healthcare providers, and also your family member and friends take place in the primary care setting as regular practice, encouraging all patients, regardless of their age, to have advance directives in place and their wish known in preparation of worst case scenario. We would like to thank you for viewing our presentation. Hopefully, we have pique some interest in DNR ethical dilemmas, as we will see these kind of situations in our practice when we become nurses.
Here are our references.